Good evening. I am Mahwash Kassi, and I welcome you all to our monthly heart failure webcast. This time we're talking about genetic cardiomyopathies. And joining me in the studio is Dr. Barry Trachtenberg, who is one of our advanced heart failure and transplant cardiologists. Salil Kumar, who is our very amazing second-year fellow who wants to be a heart failure cardiologist in the future. And joining us now from Pennsylvania is our expert panel. I'm going to introduce Dr. Musunuru. He is a leading physician, scientist, and an expert in gene editing. He's an actively participating practicing cardiologist and a committed teacher. He's an MD, a PhD, an MPH, and a master's in law. Currently, he's a professor and a genetic researcher at the University of Pennsylvania. He's a recipient of several distinguished awards, including the Presidential Early Career Award for the Scientists and Engineers for the White House. He has several NIH grants, including several R01 grants, and has an active R35 for diagnosis, prevention, and treatment of cardiovascular diseases with genome editing. He served as an editor-in-chief for Circ Genomic and Precision Medicine in 2017 to 19. And he's also an author of the book, The CRISPR Generation, the story of the world's first gene-edited babies. Thank you for joining us, and welcome.
Thank you. It's a real pleasure to be with you.
And I'd like to welcome Dr. Anjali Owens, who is an assistant professor of medicine at University of Pennsylvania. She's the founding director of the Penn Familial Cardiomyopathy Program, the director of the Hypertrophic Cardiomyopathy Clinic, and was appointed the medical director of the Penn Center for Inherited Cardiomyopathies for inherited cardiovascular disease, in 2015. She did her medical and undergraduate degree at Duke University and did the rest of her training, residency, chief medical resident in cardiology fellowship and heart failure fellowship, all at the University of Pennsylvania. She is a member of the AHA and Heart Failure Society of America, and she serves on numerous committees nationally focused on increasing awareness and educating medical professionals on inherited cardiovascular disease. And she's the principal investigator in several clinical trials investigating the role of myosin inhibitors for hypertrophic cardiomyopathy. Welcome, Dr. Owens.
Thank you. It's a pleasure to be here.
Next, we have Miss Lily Hoffman-Andrews, who's a genetic counselor at the Penn Center for Inherited Cardiac Disease. She is a graduate of the Human Genetics and Genetic Counseling program at Stanford University. In addition to her clinical work, she gives lectures and supervises students from the Penn Genetic Counseling graduate program and is involved in clinical research. We strongly feel that genetic counselor is an integral part to an inherited cardiomyopathy clinic and program, and we're so thankful to have you as part of our team.
Thank you. Very happy to be here.
So with this, we're going to start a little bit about genetic basis of cardiovascular disease. Dr. Trachtenberg.
So great. So I think it's important to understand the concepts, and you can see here, different cardiovascular diseases on the left panel. We're going to be focusing predominantly on cardiomyopathies, but you can have different patterns of inheritance. So, for example, on the left of the graphic that you see, you can see a monogenic type of inheritance, which is these are more rare variants. But they can have an outsized effect on having disease, as opposed to having oligogenic inheritance, which is several genes that can impact a disease, and polygenic, when you have multiple genetic variants that can be a factor, but they're less likely to be causative in any one particular disease. For the purposes of our discussion today, most of the cardiomyopathies fall into the monogenic inheritance pattern, and that's what we'll be speaking of predominantly.
So just going over what we're going to do today is we're going to have a case-based discussion, and we're going to present some cases, talk about who should we order genetic testing and how should we interpret these results, and then what are pitfalls of some of the genetic testing that we do, and what is the role of genetic counseling and talking to families. Now I'm going to hand it over to Dr. Owens, if you could talk about the genetic forms of cardiomyopathies.
Sure. So as Barry mentioned, for the monogenic conditions, we have clinically available genetic testing that can be used for patients who have disease. and also to identify family members who are at risk to develop the disease because they inherited a pathogenic or disease-causing variant from one of their parents. So pictured here on the chart are the major types of familial cardiomyopathies, including dilated phenotype, a hypertrophic phenotype, and a arrhythmogenic phenotype that can include both right and left ventricular involvement. Not pictured here are two other phenotypes that we see in inherited forms of cardiomyopathy, including a restrictive phenotype and also non-compaction. So all of these conditions can be caused by just a single rare variant in a gene, as Barry alluded to. And most of these conditions are autosomal dominant in transmission. And they may be more prevalent than you might think, with hypertrophic cardiomyopathy, for example, occurring in at least 1 in 500 individuals. It's really important that we recognize these inherited forms of cardiomyopathy, one, so that we can be proactive about diagnosing family members and initiating early treatment, and also to prevent cases of sudden death that can unfortunately be the first presentation of disease in some of these cardiomyopathies. Next slide, please. Just a brief introduction about what we've learned over the last several years in terms of the overlap in phenotype and also in the range of what we can see in terms of disease severity in these cardiomyopathies. We know that there's overlap between the phenotypes. And on the next slide, we know that over the past several years, what we think of as perhaps toxins like alcohol or cardiomyopathies that are caused from chemotherapy, all of these environmental triggers may be a second hit on top of what's a genetic predisposition that someone's born with. And we think that this interplay between genetic predisposition and environmental trigger may be what brings out or manifests the phenotype of cardiomyopathy. And that may be part of what accounts for the differences we see between family members, where one family member can be very severely affected and another family member with the exact same genetic variant may be mildly affected or asymptomatic and only diagnosed through screening. So on the next slide, before we get into our case, is the genetic architecture of inherited cardiomyopathies. And as you can see, it's pretty complicated. And we don't understand a lot of the interplay between these phenotypes and the genes that cause the phenotype. We know that there are over 100 genes that have been implicated in genetic forms of cardiomyopathy, and that there can be non-cardiac manifestations. And again, this is another point for cardiologists who are treating patients. If you see a patient that may present perhaps with neuromuscular symptoms like a mild skeletal myopathy or muscular dystrophy, or even patients that have dermatologic manifestations that may hint to you that they have an underlying desmosomal gene mutation or an arrhythmogenic cardiomyopathy. And one relatively untouched area up on the right is the genetic basis of congenital heart disease. And hopefully over the years, we will be learning more and more about the basis of congenital heart disease.
On the spot, and when do you order genetic testing, Dr. Kumar?
So when we approach a patient who we suspect may have a genetic cause to cardiovascular disease, it's first and foremost important to do a rigorous clinical phenotyping of our patient. Next, and for every patient that we suspect has a genetic cause for cardiovascular disease, is we should do a 3-generational family history. And if putting together these two factors, we then either diagnose a genetic cause for cardiovascular disease or we strongly suspect it, that's when we should consider genetic testing as our next step. The next question is, who exactly should we test? And practically, it's usually the patient that's in front of you that we do test. However, it's the patient who has the most severe and most distinct form of the clinical phenotype of the genetic cardiovascular disease in question that we should be testing, because that gives us the highest chance of finding the putative pathogenic variant. And of course, before we do any kind of genetic testing, it's important that we counsel them beforehand and get appropriate informed consent. And this could be from the cardiovascular physician if they feel like they have the genetic background and if they feel like they are comfortable in doing so. Or more importantly, it would be great to get genetic counseling from a board-certified geneticist or a genetic counselor, and who would also then be there to follow up with the results when the patient gets them.
So this is from the updated guidelines, and Dr. Musunuru is the first author on this one. So my question to you, Dr. Musunuru, is what do you think the new and updated guidelines add to our clinical practice currently?
Yeah, so what has changed over the last, say, 2 decades or so is that, back around the turn of the century, we had very little idea what actually drove inherited cardiomyopathies. We knew that certain types of diseases, heart diseases, were inherited. They ran in families, but we had no idea of the genes that were actually responsible for them. And so there's been substantial work over the last couple of decades identifying many genes that are implicated in these different inherited cardiovascular diseases. And so that's entirely transformed genetic testing, right? You can't test for things unless you know that they might actually be causes of diseases. And so now there are gene panels that allow you to, for example, a patient in front of you who you either have diagnosed with hypertrophic cardiomyopathy or highly suspect have hypertrophic cardiomyopathy and maybe have the family information implicating that it's an inherited form of cardiomyopathy, then there are panels available from different testing laboratories that include various genes that have evidence behind them as being causes of inherited cardiomyopathy that you can then send out for the genetic testing and hopefully get a result that makes sense for the disease and that can then inform the next step of care for that patient. And I should also emphasize that something that's increasingly appreciated is now that we have the ability to identify or potentially identify genetic variants or mutations that cause disease in the patient who's in front of you. Again, these are inherited cardiovascular diseases that run in families. And so once you've made that both clinical and genetic diagnosis for the patient in front of you, it's incumbent upon you to think about that person's family members, because some of those family members are very likely to have the same exact mutation, and for that reason might be at risk, or certainly are at increased risk of having the same disease. And maybe they are younger and haven't yet manifested the disease. Maybe they are of an age when they have already developed stigmata of disease, but because no one has looked, there's no way to have known that they might have been at risk. It wouldn't be appreciated. So this is what prompts cascade genetic testing, the idea that any first-degree family members of a person who's had a genetic diagnosis, we recommend that they would get testing for the same mutation, and anyone who has the same mutation would then be clinically screened as appropriate to ascertain whether they have any signs of the disease in question. And any individual, any first-degree family member who's found to be mutation positive, then you would build outwards in the pedigree and ideally do cascade genetic testing of any direct relatives of them who have not already been cascade genetic tested. And so you can kind of build out throughout the family and ideally ascertain everyone who has a mutation, regardless of their health status, in order to figure out whether they're at future risk of disease.
Yeah, I think that's a really great point, that sometimes we have to think beyond just the patient in front of us, but actually consider their whole family as potential patients. And I think before Dr. Kassi presents the next case, one housekeeping item, we do have the opportunity for our audience to ask questions. So I just wanted to highlight that, how they can do so. So there's 2 ways they can do it. One is they can join by text. They can text DEBAKEY, that's DEBAKEY, to 37607. So that's texting DEBAKEY to 37607. Then you can text your message. Or you can go on your smartphone or computer and go to PollEV, that's Poll, POLLEV.com, and then enter DEBAKEY. And then you can respond to the activity, and then you can ask the experts any question you'd like to know. So with that, we'll hear about our first case.
So our first case is basically a 32-year-old gentleman that was sent to us for evaluation of cardiomyopathy, as he had a very strong family history. So he had already undergone an echocardiogram, and his cardiologist was suspicious that there were probably prominent trabeculations in his LV, although the LVEF was okay, the right ventricular ejection fraction was okay, and he was fairly asymptomatic. This then led to a cardiac MRI, and his cardiac MRI basically showed LV non-compaction, and this is an image of his cardiac MRI. Then looking in deep diving into his family history, it turns out his father basically had a diagnosis of Epstein and non-compaction. He himself was married, had 3 children, one of whom unfortunately had died at infancy. And there was an autopsy that was performed, but my patient was not very well aware of the autopsy results. The 2 other boys were healthy. He also mentioned that he had 4 aunts, and they had heart issues varying from congenital heart disease to arrhythmias. So, but he was not very specific about what those were really. So I'm going to direct this to the panel. So what would you do next? At this point, Lily, if you want to take over.
Sure. So as Dr. Kumar mentioned, genetic counseling would be very important in this family before proceeding with any genetic testing. And you always want to do both pre-test counseling and post-test counseling when results are back. So when we're doing pre-test counseling, we talk with patients about the purpose for the test, the possible results, positive, negative, or VUS. We find it's very important to prepare patients for what these different types of results may mean, especially a negative or VUS result, because these are often difficult to understand for patients. The concept of an uncertain variant of uncertain significance or an uninformative negative, we find that patients understand these results much better when they're prepared for them beforehand. A big question patients always have that we always discuss is cost of testing. A lot of patients and even cardiologists and other doctors are under the impression that genetic testing is prohibitively expensive. This has changed a lot in the past several years, and insurance coverage has gotten better, and a lot of labs offer self-pay programs and other ways to make testing affordable. And one thing that patients often also ask about is insurance discrimination and the risk of insurance discrimination. This is less relevant for patients who have a cardiomyopathy because the insurance discrimination that they get is going to be based on the fact that they have a cardiomyopathy. But for unaffected individuals, they often want to know, if I get a diagnosis of having a predisposition to a genetic condition, is this going to affect my eligibility for insurance? There are laws in the United States that protect against insurance discrimination for genetics in health insurance, and they protect against genetic discrimination in employment, but they don't cover life insurance, long-term care insurance, or disability insurance. So this is something we talk about with patients. And then, of course, when the results are back, there's the post-test counseling. And, in some cases, we are talking about how these results impact management. I would say that that's not as common as we would like in cardiomyopathy, where the results can really directly impact management. Oftentimes we're talking more about management and surveillance of family members. So we're having that conversation about family members getting tested, or if the results are negative or inconclusive, talking about family screening. So post-test counseling is just as important when results are negative or inconclusive, because oftentimes family screening is still recommended, and we need to make sure that patients understand that. And for patients who are of reproductive age, they're often interested in the risks of passing on a pathogenic variant if one is identified, and whether anything can be done about that. So we often talk with patients about reproductive options, including prenatal testing and pre-implantation genetic diagnosis.
Thank you, Lily. I think we put you on the spot, and that's a lot that you covered. We really appreciate it. And that's why it's really important that the genetic counselors at the center and core of a good inherited cardiovascular disease center. Moving on, we're just going to briefly touch on the layers of genetic testing, and Barry, if you want to talk about those.
Sure, yeah. So I guess, just so people understand what we're actually testing, there's different things that we can test. So there's whole genome sequencing, which is basically sequencing sequencing all of your DNA, including both your coding DNA, which makes proteins, and your non-coding DNA, which does not. And that's mainly for research purposes. You also have exome sequencing, which is just looking at sequencing of all your protein coding regions, and so it's excluding the introns and just looking at the exome. So, but in terms of what we do clinically, most of it is what we consider disease-targeted genetic panels. So certainly for cardiomyopathies, that's what most of the commercially available panels will do, of which there are several companies and organizations that have gene panels for a variety of cardiomyopathies. So, for example, for long QT syndrome, it might be these are 17 panels for arrhythmogenic cardiomyopathy. Typically, it's around 16 genes, depending on which company you're using. Hypertrophic cardiomyopathy, but typically over a 40 gene panel. For dilated cardiomyopathy, it's typically around 50 to 70 genes, even though most of them are within the 20 more common genes. And then for hereditary transthyretin amyloidosis, it's just one gene with potentially over 120 different mutations that you can test. And so you have, depending on the test, you have a panarrhythmia panel, you have a pan-cardiomyopathy panel, and then right now there's some companies that are offering free genetic testing, and this really came with the amyloid world developing so quickly and having new drugs that are available to help these patients. So they're offering free genetic testing, and so I just got off an amyloid working group phone call, and we were talking about this, and one of the doctors on the call said, well, I just get the whole panel for my amyloid patients, and then it comes back with some other VUSs, and then I don't know what to do with it. So just for our experts, what do you think about that approach?
I would say more is not always better when it comes to genetic testing. And the more genes you sequence, the more likely you are to find a variant of uncertain significance or a gray zone result, which can then be, cause psychological stress and anxiety for the family. So one of the very important things to do in your pre-test counseling is understand the person that you're dealing with and the family that you're dealing with. What is their, appetite for uncertainty, and how comfortable are they with uncertainty? And if you have a family that's not very comfortable with uncertainty, and you don't have a lot of affected individuals with the phenotype to track a variant of uncertain significance, then it may be best to stick with a smaller panel that's targeted toward a specific phenotype that the family has.
So this brings us to our first question. Can genetic testing on striated muscle or endomyocardial biopsy samples provide additional information compared to genetic testing on blood samples? I'm going to direct this to the panel.
So maybe I can take that one, and then my colleagues can add any additional thoughts they have about it. So in principle, the typical person, the DNA content is the same in all the cells of their body. So it should not really matter whether you're checking for a genetic mutation in DNA that's obtained from blood cells, which is how it's typically done, although sometimes, or in many cases, it's done through saliva samples or cheek swabs. Again, the idea is that all these different cells are the same. So being able to actually take the DNA from the biopsy samples from a heart, for example, probably is not going to give you any additional information. Now, there are very unusual cases where there's so-called mosaicism or chimerism, where a mutation happened at the fetal stage, and so it ends up that some cells in the body have a mutation and other cells do not. In these very rare cases, it might be that looking for the mutation in the blood might actually lead you to think that the person is negative, but it might turn out that some of the cells in the heart actually do have a mutation that actually cause heart disease. That is exceedingly rare. It's not something I would advise thinking too hard about for the patient in front of you, because it is so unusual. I think, generally speaking, either a blood-borne test or cheek swab or saliva test are all equally valid for that purpose.
Thank you.
The other very unusual circumstance we run into, again, very rarely, in the transplant world is when a donor heart actually ends up having a cardiomyopathy phenotype once it's already in the recipient. And in that very rare situation, we have used endomyocardial biopsy sampling to sequence DNA and see if we can find a pathogenic variant causative of cardiomyopathy in the donor.
That's very
Again,
interesting.
very rare.
Fascinating. So moving on to this, so as Barry mentioned, you could do whole exome sequencing. So the question really we had for you, Dr. Musunuru, is why not sequence everybody and see what mutations or variants they have? Is that a good thing to do or not so much?
I would say that's definitely not a good thing to do. And the best way I can explain it is, you could ask a very similar question: why not do a whole body CT scan or pan scanning routinely for everyone? And I think this audience will intuitively, immediately know the right answer, which is, wow, you're going to turn up a lot of incidental findings that are entirely meaningless for someone's health. But once you've seen something and you feel the obligation to go after it, do more testing. And there are very few medical procedures that, of course, are entirely risk-free and can lead to complications. And you can end up doing more harm than good in those sorts of scenarios if there's not a good clinical justification for doing the sequencing. Now, the challenge is that many people now have access to whole exome sequencing or whole genome sequencing or whatnot through direct-to-consumer services. So a couple years ago, there was a company in the UK, I won't say exactly what the company is, since I don't necessarily want to encourage this, but right around Thanksgiving, they had a Black Friday special where they were offering whole genome sequencing for $200. And I confess I saw it and I signed up for it myself with the reasoning that, well, I'm a geneticist and, I actually do have the wherewithal to properly understand what I find in my genome, whereas the typical layperson does not. And so, more and more, we're going to find ourselves in these situations where a healthy person, maybe even a young person, just out of curiosity, gets direct-to-consumer testing, or maybe they get it as, a holiday present or whatever, and it finds things in genes that are linked to disease, maybe cardiomyopathy genes. And there's no reason to suspect that person has any predilection for cardiomyopathy. They have no clinical signs. They have no family history. But they have that test that they got themselves without any providers or genetic counselors or whatnot involved, and they bring it to their provider. And the provider is put in the very difficult situation of trying to figure out what to do with that information. It's an incidental finding, just like some tiny lesion you find on a pan scan. It's hard to tell the person, oh, it doesn't mean anything, you don't have to worry about it. I mean, they can read, they can look things up on the internet, and they can see, hey, there's a mutation in this gene, and people with these mutations in this gene have cardiomyopathies, and they can put them in very anxiety-provoking situations that can be hard for a provider to address.
Absolutely. So on that note, we did have genetic test results coming back to our case. Now this is the father who had Epstein and non-compaction. Lily, I'm going to ask for your help, but I can just state that he had two variants of unknown significance. One is in the PTPN, which is related to Noonan syndrome, and the other one was in the MYH7 gene, a deletion including exons 11 to 14. And it was also an unknown significance variant. Now I put up the results exactly as they come up because I want the general audience to know what the results look like, and Lily is going to walk us through those and how to interpret this.
Great, yeah, so you can see at the top here what type of panel this is. This is a cardiomyopathy sequencing and del-dup panel, and a list of the genes that are sequenced. Now, when it comes to cardiomyopathy and levels of evidence, not all genes are created equal. So there are some genes here that have very strong evidence associating them with cardiomyopathy, others that have weaker evidence. There are genes that are associated with syndromic conditions, genes that are associated with isolated conditions. So you really have a diverse set of genes here. And then the actual results, we see here we have two variants of uncertain significance. VUSs are the bane of a geneticist or a genetic counselor's existence. They are very, very difficult to understand and deal with, and very difficult for patients to understand. So there's a lot of counseling and a lot of work that goes into interpreting these results and explaining them to patients. So the other thing here is that not all VUSs are created equal. So you really have to dig into the evidence for each variant that you find to see how likely it is to be related to your patient's phenotype and whether further investigation is warranted. So the first variant that the report goes through is the PTPN11 variant. And they start with the gene level evidence and the phenotype associated with the gene, which is Noonan syndrome. Noonan syndrome is a syndromic condition that can have cardiomyopathy as a manifestation. It's very penetrant, meaning that people with Noonan syndrome, you're usually going to be able to know that they have Noonan syndrome from their clinical phenotype or have a strong suspicion. There are physical features, including short stature and dysmorphic features that often go along with Noonan syndrome. So when you find a variant of uncertain significance in a gene associated with a syndromic condition, you really want to assess, does this family or does this person in front of me have anything suggestive of the syndromic condition? If not, you can often kind of put it to the side. But you do, of course, want to look at the variant in detail. And so on the next slide is the variant level data. This says that this variant has been observed in childhood cancer, but it hasn't been reported in anyone with Noonan syndrome. It is reported in the general population at a fairly low frequency, but certainly a higher frequency than the frequency of Noonan syndrome in the population. So already that's pointing us a little bit against pathogenicity. The interesting thing here is that other missense variants at the same amino acid residue have been reported in association with Noonan syndrome, which is something that pushes us a little towards pathogenicity. So as you can see here, and this is quite common, we have sort of limited and conflicting evidence about this variant. So with a variant like this, we're not going to make too much of it at this point, most likely because of what I mentioned, that it's a syndromic condition. And as far as I know, in this case, we didn't have suspicion for a syndromic case. Right. That's kind of the last word on that variant, is that it's really a variant of uncertain significance. Now, the MYH7 variant is a little more interesting. So the MYH7 gene is associated with a variety of types of cardiomyopathies and increasing evidence. It's associated with congenital heart defects as well as in its biallelic form associated with skeletal myopathies. That's the gene level evidence for MYH7. And then on the next slide, we look at the variant. This is a deletion, meaning there's a piece of one copy of this gene that is missing, of exons 11 to 14. And it's always important to look at where a deletion is and if it goes into any other genes. This one is within the MYH7 gene. It doesn't overlap any other genes, but it's very important to look at that because if a deletion extends into neighboring regions, you can be thinking about it affecting other genes and other things to look for. But this variant hasn't been reported as pathogenic or benign. It hasn't been reported in the general population. And the tricky thing about this variant is that deletions in MYH7 in general, up until pretty recently, had not really been associated with disease. Most variants in MYH7 associated with cardiomyopathy are associated with missense variation. But the interesting thing about this gene and this case, although this is not really noted in the report, is that MYH7 variants have been reported in this kind of unique combination of findings of Epstein anomaly and left ventricular noncompaction. There are other families with this constellation of features that tend to be very variable within the family, reduced penetrance. Some people have one or the other, some people have both, some have none. In these families, predominantly missense variants in MYH7 have been identified. So kind of coming into this case, if you showed this family to a cardiovascular geneticist or genetic counselor, they might already be able to tell you, I'm suspicious of MYH7. So that makes this a more interesting finding, this MYH7 deletion. So you can see that even though both of these variants are classified as variants of uncertain significance, we're much more suspicious of one than the other. But certainly nothing definitive at this point.
Dr. Owens and Dr. Musunuru, do you want to add on to any of this before I move on to the next slide?
I think just as Lily highlighted, you go back to your phenotype that you're dealing with in the family and see if what you're seeing genetically matches the phenotype. And that combination of Epstein anomaly in some individuals, LV non-compaction in others, really does make you suspicious of the myosin heavy chain variant.
Great.
And the one thing I would add is that if this, or if the MYH7 variant, or if you're just talking about an individual and you have some test results like this, and there's this uncertainty over whether a particular variant is responsible for the person's disease, it can be helpful when possible to look closely at the family, identify family members who have the same condition or have signs of having a similar condition, really tying the inherited pattern. And then what you'd like to be able to do in an ideal world is test the entire family. It's not always practical to do so, but test the entire family. And what you're hoping to see is that the variant tracks perfectly with the disease presentation. So everyone who has signs of the disease have the variant in question, and everyone in the family who is healthy doesn't show sign of the disease, does not have the variant. If you can get that perfect tracking, that makes for a much more compelling case that the variant is truly causal for the disease. Now, unfortunately, it's rarely black and white. You don't often get such nice patterns. It's not often practical to actually be able to do testing of the entire family. But it is something to keep in mind. If there is a strong correlation between mutation or variant status in the family and disease presentation, that can be a very big and arguably the most compelling clue that there is a causative relationship.
Thank you. On that note, because some of our audience may not know what variants of unknown significance mean and how they're classified, Lily, if you could just go over some of how it's reported and how the report is given to us in a genetic test result.
Absolutely. So in 2015, the American College of Medical Genetics published these standards and guidelines for how clinical laboratories should classify variants on genetic reports. Before that, it was a little bit of the Wild West. There were some guidelines, but laboratories were often using their own kind of criteria that they had developed. And so there was a lot of discordance between laboratories in terms of how they classified variants. You could go to one lab and be told that a variant was disease-causing, and go to another lab, be told it was variant of uncertain significance. Now, that's still true, but these criteria were put out to try and lessen that problem and create kind of standardized variant classifications across labs. So pathogenic in this scheme means fairly definitively disease-causing, whereas likely pathogenic is set at a threshold, or attempted to be set at a threshold, of 90% or more likelihood of pathogenicity. So some level of uncertainty about pathogenicity, but 90% or more confidence that it's pathogenic. Now, variant of uncertain significance runs the whole gamut from 89% down to a lower percent. So some of them are more suspicious than others, as I said, with the case. These kind of subclassifications of BUS favoring pathogenic and BUS favoring benign, you won't actually usually see on a report. That's often a judgment you have to make for yourself based on clinical evidence. And then likely benign and benign variants are not reported out because there is not much to say that they are disease-causing. Where you might see them is sometimes one of these variants in these other categories will be reclassified to likely benign or benign, and you might receive an updated report stating that.
Thank you, Lily. And this is kind of the framework of how pathogenicity is decided. Lily, if you have any comments before we move on to the next slide.
Yeah, I mean, we could spend an hour just on this slide. The variant classification guidelines are very detailed. And there's lots of lines of evidence that go into saying whether a variant is pathogenic or uncertain or benign. I would say the most important thing to take away here is that clinical data is king, whether that's case data, segregation data like Dr. Musunuru was talking about. You really want to see within a family that a variant is tracking with disease, and you really don't want to see anyone with disease without the variant. That's very strong evidence against pathogenicity. Population data is very important. If you see that a variant is very common in the general population, in one of these databases, EXAC, NOMAD, which are databases of non-selected for disease, so attempting to be kind of representative of the general population, exome and genome data. You can look up how frequent a variant is in these databases. And if it's quite frequent when you're looking at a rare disease, that's pretty strong evidence that this is not pathogenic. And then I would caution that computational and predictive data in most cases should be taken with a grain of salt, and really clinical data should come first. The one exception is when a variant is predicted to be a null variant or loss of function variant in a gene where that's a known mechanism of disease. That can be very strong evidence for pathogenicity.
Great.
I wanted to point out this highlighted box just at the bottom here. This criteria here, where it says patient's phenotype or family history is highly specific for the disease, doesn't actually come up all that often, especially in a disease like cardiomyopathy, where there's a lot of genotypic heterogeneity. It's more common in things that are syndromic, where you might have a very specific set of features associated with the disease, associated with one gene. But in the case that was presented here, I think this criteria actually applies to some degree, because that combination of Epstein anomaly and non-compaction, as Dr. Owens and I were pointing out, is very specific to the gene. So I'm not sure if the laboratory applied this criteria in this case, but I think it is a case where it could be used. So again, coming back, you have to look at the phenotype and the patient and family in front of you.
So here's ClinVar, our clinical database, and Dr. Musunuru, if you could talk a little bit about it. I must premise that I found it extremely confusing when I first started using it, but if you could talk the audience through with what this really is.
Yeah, so ClinVar is a resource basically put together by the National Human Genome Research Institute. It's an attempt to codify all of these so-called expert opinions of different testing services, testing laboratories, whereby each of them, when they encounter a variant and go through their own process of curation and determine whether they believe that variant is pathogenic, likely pathogenic, uncertain significance, likely benign, benign. So those 5 categories that we just heard discussed. Each testing laboratory comes to its own expert opinion using its criteria, hopefully very similar to those criteria you saw just a moment ago from the American College of Medical Genetics and Genomics. Although you can see how complicated they are, and you can see how 2 different testing services, even if they try to apply the same exact criteria, could come to different conclusions. But what's nice about ClinVar is you can see what different testing laboratories have opined about particular variants, assuming that they've encountered that particular variant. And also, they submit the rationalization, the explanation for why they made that particular determination. They called something benign or pathogenic or VUS of certain significance. And so it's not for the faint of heart, but if you do have a test report in front of you and there's a variant and you want to learn more about that variant, you can put it into this freely accessible resource. You can basically just put ClinGen into a search engine, and it will take you right to the site. And you can type in the gene name, type in the variant, and it will pull up an entry. And in most cases, that variant will have been seen by at least a few testing laboratories. Very occasionally, a variant will never have been seen before, and then there won't be any meaningful information or any entry on it. But usually, there'll be at least a few laboratories, and then you can see their interpretations of those variants. And if you want to dig even deeper, you can actually get the explanations for why those services, those laboratories felt the way that they did. Now, often this is helpful because you'll see that they all agree. They all think, oh, this is likely benign, or oh, this is definitely pathogenic, or all this is uncertain, and having broad agreement by different groups of experts, because that's effectively what they are, lends reassurance that that's actually the right interpretation. But there are two potential wrinkles in this, and one is that with some variants, there is broad disagreement. There will be so-called conflicting interpretations. And so occasionally you'll run into a variant where some folks thought it was more likely to be pathogenic, some thought it was more likely to be benign, and others thought it was uncertain significance. So it's actually even worse than being a variant of uncertain significance. It's like what I think of as a meta variant of uncertain significance, a meta VUS, because there's not even agreement that it's a variant of uncertain significance. And those obviously make for very challenging cases when you run into one of those variants, if there's not even agreement about what it signifies. The other thing that we should touch upon is that interpretations aren't necessarily static. It's not as if you submit something to ClinVar and that's what it's going to be for the rest of time. Testing laboratories are updating their interpretations of variants based on the latest evidence, based on new publications, new data that become available, both internally in the laboratories as well as what's out there. And they will change their interpretations, and it's not necessarily so easy to keep track of when that happens. And it's not totally clear exactly whose responsibility it is to keep track and make sure that the interpretations that are in ClinVar are exactly the same as a year ago or 2 years ago or whenever the testing was actually done and the results were communicated to the patient. It could be that a couple of years later the situation has changed, and that might actually have very significant implications for the patient. So those are some of the caveats of the ClinVar resource. And the last thing I'll mention is that there's a group of researchers / clinicians, basically thought leaders and experts in the field of genetics, organized once again by the National Human Genome Research Institute. They go under the umbrella name of ClinGen, and they actually look at the evidence for individual genes or sets of variants and try to offer recommendations or guidelines as to which genes are most likely to be responsible for dilated cardiomyopathy, or say long QT syndrome. You heard earlier that long QT syndrome panels can have something like 16 or 17 genes. But if you actually look at what the ClinGen working group on long QT syndrome, after reviewing all the available evidence, what they determined is that there are really only about 3 genes that they feel have strong evidence for being responsible for long QT syndrome. The ones we all know about, QT1, QT2, QT3, the ones we learn about and the ones that we think about most when we think about long QT syndrome. And all the other genes, the evidence is weaker. They're really probably more appropriate for research use. Getting results with those genes probably is not going to be as informative. So ClinGen is playing this role in trying to do some curation. So it's not totally the Wild West, and everyone is left to their own devices. And you go to ClinVar and kind of have to decide on your own what to make of things. ClinGen is trying to provide an extra layer of curation to help the community make sense of the information you find in ClinVar.
Great. That's very useful. Thank you. I think we'll have to do another cardiomyopathy session to actually go over interpretation of this website and how to use it. But going back to how important is it to recognize the phenotype, I'm going to give this to Dr. Owens again.
It's critically important. I think, you'll find families where there is a mixed phenotype where one member of the family presents more like a non-compaction, another member of the family may have a hypertrophic form of cardiomyopathy, but recognizing that variability if it's there, or a lack of variability. If everyone in the family has uniformly, a dilated cardiomyopathy with a concomitant skeletal myopathy, I think that clinically really leads you to what you're looking for and having that pretest probability of what you think you're going to find on your genetic testing results. And that way, when you're doing the interpretation, it makes sense to you that this is the right answer for this family. And it's oftentimes confusing when you get the variants of uncertain significance. So going in with a very clear, deep phenotyping of as many family members as possible, I think is critically important when caring for the family.
So going back to our test results for actually the proband or the patient who we saw, he had basically the same gene, which was the MIH7. are partial deletion in exon 11 to 15, the same variant that his father had. I'm not going to do this next, but I'm going to talk about what happened 2 years later. So there was another referral about an 18-year-old who basically was told that on echocardiography he had apical hypertrophy and was referred to me for evaluation. His mother, who's younger, who had been very involved and was very concerned, knew a lot more about the family history, and she herself had an atrial aneurysm. And then she told me about this family, or her brother, that had Epstein and non-compaction, and whose son also had non-compaction, who had a baby boy who had passed away at infancy. So does that ring a bell? That sounded very familiar to me, and I asked them, I said, do you know that other family, and what's their names? Because their last names were different. So it turns out that the two families were related, but whereas my original patient had given me a very brief history of what had happened, she was able to provide a very detailed history. I'm not going to say because she was a woman, but maybe that was one of the factors. But
certainly part of the factor.
We can agree to that. So turns out her other sister had tetralogy of Fallot. She had 3 children, and one of whom had a PFO, but the other 2 unfortunately had died in a road traffic accident. There was one unaffected sister. One other sister basically had LV non-compaction as well. She had 4 daughters, one of whom had died at infancy with Epstein anomaly, pulmonary atresia, an aberrant tricuspid valve, and was deceased, unfortunately. And then out of the 3 other daughters, one had a baby, and the baby was found to have LV non-compaction. And she herself was unaffected at this point in time, was undergoing surveillance testing, but also got a genetic test result, which I'm going to show in the next slide. And then their brother had basically, and I'm pointing at this family, this is, he was 15 years old and had LV non-compaction. So as you can see, family history is key, and the more you deep dive into it, you have to really be an investigator and be Sherlock Holmes, try to figure out what their family history really is. And she also gave me the autopsy result for the original baby, which was my patient's son, and turns out he had a ventricular septal defect on his autopsy report. So, this highlights the importance of a good family history, and this is that daughter who did not have necessarily the phenotype, but had a son who had non-compaction, and this was the same variant that she was carrying. So I'm going to pass the baton on to the panel. What would you do next, and how would you counsel this family?
So one of the first things I would do, noting that these family members have all been tested at different laboratories at different times, and it may not have been known that they were related, would be to contact the genetic testing laboratory and provide that data to them, because with that additional data, they sometimes are able to reclassify the variant. So communication with genetic testing lab can be very impactful. If this was not reclassified and remained a VUS, then we would certainly recommend clinical screening for all the family members, anyone who had not had thorough clinical screening, to see if there was anyone who had disease that had gone unidentified. And at that point, we would not use that variant for risk stratification, but we would recommend that in affected family members who hadn't been tested for the variant, that we track that variant. As Dr. Musunuru was saying, getting that segregation data can be very helpful for reclassification. In a research setting, you kind of test everyone in the family. In a clinical setting, we try to test only the affected family members for a VUS, because testing unaffected family members for a VUS isn't always informative, since penetrance is reduced for many of these genes, and also can really raise anxiety unnecessarily when the significance of the variant isn't known. And certainly if this variant was reclassified to pathogenic, we could talk about using it for risk stratification, and as well as reproductive options. And especially in these families who have lost little ones, that is often a consideration where they're thinking about having more children, and what they can do to avoid this outcome.
Anything else, Dr. Owens or Dr. Musunuru, that you want to say about this case?
I think that's perfect information. We phenotype everyone by clinical screening and then track the variant in the affected individuals. And with this level of data, I think that going to the genetic testing company and consolidating all that information may result in a reclassification.
So I think we kind of went over the counseling part. And then, we talked about whole exome sequencing, but one of the things that we wanted to ask is why not order genetic testing for the entire family? And I think that was kind of answered, but if you have a poor phenotype and you don't do appropriate testing, that could result in a lot of misinterpretation of results. And I think that in the discussion that we have covered. So going on to interpretation of test results, Dr. Owens, if you can go over how do we interpret test results if we get a genetic test result?
Absolutely. So the importance of, how to interpret a negative test result, with Lily started to talk about early on, the yield of genetic testing for most of our cardiomyopathies is variable and certainly not 100%. So when you're looking at your pedigree, you're looking at your family history, you see multiple individuals affected with the phenotype in multiple generations, you know that this is familial. And a negative test result doesn't change that. So you know that it's still genetic, you know the risk is still in the family, we're just not smart enough to put our finger on the exact variant. So in those cases, you go back to the family, reinforce the recommendation that ongoing clinical screening takes place for the unaffected family members so that if they develop a phenotype, we're able to pick it up early and start treatment. Mm-hmm. And, as time goes on and we get better panels, we identify new genes, we have, additional analysis, then we can offer repeat genetic testing with that larger panel of genes or better technology to see if we can then identify the pathogenic variant. But most important is the messaging to the family that yes, this is still running in your family, it is still, familial disease, and that everyone still needs their hearts to be monitored.
So you're not off the hook in a sense, and the yield of genetic testing is not 100%. But
exactly.
Same about interpretation of a positive test result, Dr. Owens, if you can highlight some of that.
Sure. So again, going back to the phenotype and the variant that you get and making sure that it matches. Does this make sense with the family that you're looking at? And so, for example, in the case that you showed, yes, it does. When we see non-compaction, Epstein anomaly, you get a truncating, myosin heavy chain variant, then we're very suspicious. So one, does it match? Two, does the variant segregate with disease, as both Lily and Kiran have highlighted? You want to make sure that that's the case.
So moving on, the concepts of incomplete penetrance and variable expression I think are important, and that too, Dr. Owens and Dr. Musunuru, if you all could cover that for our audience.
And usually we cover this in the pre-test counseling so that patients and their family members know that just because mom has severe cardiomyopathy or suffered a sudden cardiac death or had to have a heart transplant, that's not necessarily the path that they're going to take. And we often encounter that in the younger generation as they consider whether or not they want to be genotyped and they consider their future. So one is saying, even if we find that you carry the family's pathogenic variant, that doesn't mean that you're going to 100% develop cardiomyopathy. So that's the incomplete penetrance. And then also the variability in expression, that if you develop disease, it may be more severe, it may be less severe than another member of your family, even with the exact same genetic variant. And so that's where environmental modifiers, other genetic modifiers might play a role. But to date, we're not great at identifying what those modifiers are and predicting what's going to happen to a particular individual.
So this brings us to our case number 2, and we're going to make this presentation short. So I'm going to have Dr. Kumar go over it in a very quick period of time. So Dr. Kumar.
All right, so we counted this patient who was a 28-year-old male who had a sudden cardiac death when he was 14 years old. And then afterwards, he got an ICD, and then he had sudden cardiac death 2 more times. He underwent multiple ablations and started on antiarrhythmic. And he came to our clinic at the age of 28, and we were curious that this patient had sudden cardiac death at such a young age. something must be going on. So we ended up getting an echocardiogram. The echocardiogram showed that there was some RV dilation. And then, of course, we got a CMR. The cardiac MRI showed that there was an enlarged RV. The RVEF was depressed. There was aneurysmal dilation of the RV and segmental wall motions of the RV. And then looking at the LV side, the LV was slightly dilated. The LVEF was borderline 51%, and there was evidence of non-CAD scar in the left ventricle. And with the history of having both ventricular tachycardia and sudden cardiac death that wasn't attributable to the RVOT, and having evidence, cardiac MRI evidence of ARVD, we could come to a conclusion that he did have ARVD. So the next thing we did, of course, is we obtained a family cardiac history. And if you could go to the next slide, we found that our patient has has a brother and a sister. The brother and sister at this point are still undergoing clinical phenotyping and clinical surveillance. The mother ended up having multiple palpitations, and so she got a Holter monitor. The Holter monitor showed that she had NSVT, and that was kind of her clinical phenotype so far. The patient has a wife, and they both had a baby. So at this point, we have a very young couple who has now been diagnosed with ARVD, and they have this new baby. So Ms. Hoffman, how would you counsel the family, and what other tests would you order at this point in time?
Yeah, so I would definitely counsel the family that ARVC is a genetic disease, that with genetic testing, we might be able to identify a pathogenic variant that would be useful for risk stratifying family members, including the young baby. But the yield of genetic testing in ARVC is incomplete. It's very incomplete. It's less than 50%. So oftentimes we do not find a pathogenic variant. So I'd make sure to counsel them as well that if we don't find a pathogenic variant, we're going to be counseling clinical screening for his relatives.
As we can imagine, that provokes a lot of anxiety to have a little baby and have those questions in mind. So I think that's where genetic counseling is very important. So moving on to the genetic test results, so as the ARVD panel was ordered, so Sal, if you want to go over the genetic test results.
The genetic test results show that he had a mutation in RBM20, and it was a missense mutation. And of course, it came back as a variant of undetermined significance. The mother also had undergone genetic testing and had the same exact genetic mutation when RBM20, and this was still classified as a variant of undetermined significance. So at this point for the panel, how would future phenotyping change how we think about this case? And
Lily, do you want to take over about how this case is a little bit different than the last case, but I think if you can hone in on some of how to interpret this test result in this context.
Absolutely. So this variant, with the gene level evidence, RBM20 is a variant that can be associated with arrhythmogenic cardiomyopathy. But you have to be aware that gene level evidence is not enough. Just because you have a variant in a gene associated with disease, you have to look at the specific variant as well, because there actually is a lot of rare benign variation in the human genome. So looking at the specific variant, it really hasn't been reported in anyone with disease, and it is present in the general population at a low frequency. So really this is kind of a middle of the road VUS. Certainly tracking it in the mom, who has a little bit of a phenotype, makes it a little more suspicious, but she had a 50-50 chance of having the variant, so it doesn't really give you that much additional evidence, and certainly not enough to reclassify it or use it for risk stratification at this point. So these are the kind of variants that are very challenging to kind of explain to patients. It's hard for a patient to see that they have a variant in a gene associated with disease and really understand that it could be not it. It could be a variant in some other gene that isn't even on our panel. So that's a very hard situation for a family to be in, especially when they have anxiety about young family members.
So you would recommend continued surveillance and for the child, even if they did not carry that particular variant, correct?
Exactly. And I would not recommend testing the young man, the baby, for this variant at this point, because it would not change clinical management.
Great. So overinterpretation or not appropriately following variants of unknown significance over a long period of time are important points to make to the audience. This brings us to just one important study that I thought was important, which is about variant reclassification that can occur over time. And this was, I think, first of its kind study where they looked at ARVD genes and looked at the ACMG guidelines and saw how many of these variants were reclassified. So interestingly enough, 58% of the variants were reclassified and 41% were clinically relevant. And genetic variations occurred less in the PKP2, which is basically the desmosomal, as opposed to non-desmosomal variants, and missense variants were more likely to be reclassified. 10% were downgraded from a definitive to a borderline diagnosis of ARVD. So you not only does the variant classification can change, but also the whether they have the disease or not could change with this variant reclassification. And 38.5% of the pathogenic variants identified in the family members during cascade screening lost their pathogenicity. So I think this is kind of an important paper. Dr. Musunuru or Dr. Owens, if you have any comments on this particular paper.
A huge point that with ARVC, genetics are part of the diagnostic criteria, which is distinct from the other forms of cardiomyopathy, where you make a clinical diagnosis of HCM or restrictive cardiomyopathy. With the arrhythmogenic right ventricular, cardiomyopathy guidelines, genetic information is part of the criteria, and it favors the right-sided presentation of arrhythmogenic cardiomyopathy. So I think it's a huge point that if you're downgrading variants to, VUS from likely pathogenic or pathogenic, that it's going to impact clinical care.
So this was a paper, and Dr. Kumar, do you want to talk about this?
Yeah, so there's a recent paper that came out in Circulation about how RBM20 has been associated with arrhythmogenic cardiomyopathy, and specifically mutations in exon 9 and 11. However, in our case, it's this mutation did not occur in exon 9 and 11, and this is something for us to keep an eye on in the future.
So this brings us to role of therapeutic genome editing in cardiomyopathies. And Dr. Musunuru, if you could talk about this a little bit, and then we'll handle some of our questions. We'd really like to hear what your thoughts are.
Sure, absolutely. So the last thing I want is for this to be an advertisement for my book, but if you are interested in genome editing, both the good side, the potential to help patients with very grievous disorders like cardiomyopathies, as well as what you could think of as the bad side, which is the attempts by a Chinese scientist to do gene editing at the embryonic stage. So even before implantation, basically to make gene-edited babies, which I think was properly, widely, and roundly criticized as being far too premature and being unethical, as well as scientifically dubious. If you want to get the full flavor of both sides of that issue, I would certainly point you to the book. It's written in what I hope is an accessible and fairly non-technical way to communicate not just the scientific and medical issues, but also the ethical issues. But putting aside the issue of so-called germline genome editing or editing of embryos, but focusing instead on somatic genome editing, which is genome editing in people who have already been born and already are showing signs of very serious disease, and for whom there may not be good treatment options or not enough treatment options, then I think there's a lot of potential for good. And undoubtedly, if you keep close track of this sort of thing, you may have heard about, most of you will have heard about a patient or two who just in the last year have at least shown evidence of being cured of sickle cell disease by using CRISPR to modify the gene involved in sickle cell disease to correct it, effectively to correct it. Hematopoietic stem cells taken out of the body, edited and put back in, leading to what appears at this point to be a cure. That's very exciting that a disease like sickle cell disease can now be treated in a way that is potentially curative, which has never really been possible before. And so that just speaks to the power of genome editing. So how does it apply to cardiomyopathies, other cardiovascular disorders? Well, what you may not know, you may be surprised to hear, is there's actually one form of cardiomyopathy for which genome editing is already in clinical trials. And it's transthyretin amyloidogenic cardiomyopathy, TTR cardiomyopathy, which has gotten a lot of attention just in the last few years. And the reason that this is ahead of the other cardiomyopathies is because the target organ is not actually the heart. Even though the heart is the end organ that gets damaged in the process of amyloidosis, the origin is actually the transthyretin protein, which is made exclusively or largely by the liver. And so what genome editing is allowing us to do is actually go to the source of the amyloidogenic protein and turn it off right there. So essentially knock down the TTR gene, which makes transthyretin, turn it off within the liver, which means that there's less of the protein in the bloodstream, less opportunity for amyloid deposits to end up in the heart and cause the cardiomyopathy. And so this is an exciting approach because what it means is that it's potentially a once and done sort of therapy, a cure. We permanently knock down the gene, turn off the gene in the liver using genome editing, which is at the DNA level. So it's not a medication you're taking every day. You receive one infusion, the editing happens, and then in principle it is permanent. Permanently reduce transthyretin levels and hopefully either halt the disease or, best case scenario, maybe even reverse the disease process. And so clinical trials just actually started a few months ago. And so we'll see. I expect we'll all be hearing later this year the results for the first patients who were treated with this genome editing therapy for transthyretin cardiomyopathy. The other cardiomyopathies, I think, will be further behind. It's more challenging because there the target organ is the heart. The genes that are at fault are actually affecting the heart muscle directly. And for a variety of reasons, it's harder to do genome editing in the heart. It works extremely well in the liver for reasons that are not totally clear. It doesn't work as well in the heart muscle cells. The other challenge is delivery. The liver is an organ whose purpose is to clean out the blood. So if you put some sort of drug or delivery vehicle into the blood, it invariably will get taken up by the liver, which makes it very easy to target, whereas the heart is much more selective in what it takes out of the bloodstream. So I think we will get there in due course, but transthyretin will certainly be the first cardiomyopathy that will likely be cured by genome editing, and then the others we'll have to see what the coming years will bring.
Yeah, that's absolutely incredible to think about that and how far science has come, and definitely looking forward to seeing those results. We're running a little behind time. I think we're going to start with a couple questions from the audience, and the first one is there a place for transcriptomic techniques in cardiomyopathies? I can start with that and then we'll put it to the panel. I think in terms of, so transcriptomics, as opposed to DNA sequencing, this is RNA expression of genes and looking at those as biomarkers for disease. So we see in transplant literature using gene expression profiling definitely is used clinically for evaluating patients for rejection. We use it all the time for heart transplant patients. In terms of cardiomyopathies, there is some research data, from University of Miami, where they looked at transcriptomics of a biopsy from myocardial biopsy, showing that it can differentiate myocarditis from other types of cardiomyopathy. There's all sorts of research in terms of coronary disease diagnoses, but nothing else, clinically ready for prime time for cardiomyopathies that I'm aware of. But if any other comments from our panel about transcriptomics and cardiomyopathy specifically?
Yeah, I think the larger point and takeaway is that the genetics, which is focused on the DNA, and the transcriptomics, which are focused on the RNA. The RNA are short-lived molecules that are transcribed from the DNA. They really reflect two entirely different situations. So genetics, DNA, your DNA by and large is the same on the day you're born as the day you die. It's very stable. And so it's much more useful to assess long-term risk for diseases. If you know very early on that you have a genetic variant that's pathogenic, it puts you at risk for cardiomyopathy. You can act upon that information early, and it can continue to guide management over a long period of time. Whereas transcriptomics our levels of RNA molecules and the identity of those RNA molecules they're much more labile. And so they're much better at reflecting acute situations. So if there is, a situation with heart failure and one is trying to differentiate the same example you brought up, myocarditis versus, some other type of issue that's leading to heart failure, then I could certainly see transcriptomics being useful at distinguishing between different states and helping to better diagnose what's happening in the acute setting. And of course, you brought up the very good example of transplant rejection, where the transcriptomic status, again, reflects what's happening in real time at that moment and can tell you whether you're in an acute rejection state or even a chronic rejection state.
Great. So the last question we have from the audience is, what features can we use to assess the pathogenicity, or the pathogenic potential of a mutation in a particular individual with no symptoms and with no cardiac imaging, with normal cardiac imaging? I guess the question would be, why would you be testing the genetics in the first place on this patient? But so if you have a pathogen, let's say, you could think of certainly an example with TTR, as you mentioned, which, very common mutation, 3 to 4% of African Americans carry that mutation. That would be one example, but overall, what would you make of someone that had a positive mutation with no symptoms and no obvious imaging abnormalities?
Yeah, what I would say is it's all about context. How is that variant identified? So if it was in the context of cascade genetic testing because there was a family member who had the same variant and who unequivocally had disease, then that puts the person who is currently healthy but has that variant at substantially higher risk of eventually developing the disease compared to the average person in the population, or even the average person who has that variant, because there is that familial connection. It is known that in that family, that variant did drive disease in somebody, and that reflects on one's personal risk as well. Now, if it's a situation where a healthy person stumbled upon this variant because they chose to do direct-to-consumer testing, was done entirely outside a clinical context, then that has a very different meaning. I mean, I would agree with your statement that, probably they shouldn't have gotten tested, or we shouldn't be, trying to get that information and act on that information in the first place. But, a result is a result, and it's there. That person's risk is going to be less than the person in the first scenario, where there's a clear familial implication. And it has to do with the issues of penetrance and variable expressivity and so forth that we already discussed, that just because you have a variant doesn't mean that you are necessarily going to get the disease. There are other environmental modifiers, genetic modifiers that come into play, and it might be that you are lucky and have a genetic background that's resistant to disease, like contributions from many other diseases, that even though you have that pathogenic variant, it's never going to cause a problem. And so, this just highlights one of the challenges. If we don't really have context into which to place the variant, it becomes very, very challenging to try to understand what that means for that person's risk over their lifetime. Certainly, I turn to my colleagues to see if they have anything to add to that.
Yeah, I'll just add that this is a increasingly common scenario we're actually seeing as a referral indication to clinic, is people who have direct-to-consumer findings or incidental findings on genetic testing for other reasons, who have a pathogenic variant identified, who have no known phenotype or family history. And it is very challenging to know how to counsel these patients because we don't actually know what their risk is of developing the phenotype. But I will also add that some of these patients do turn out to have a phenotype when they have that first evaluation. So sometimes we're able to ascertain that someone had a phenotype that they might never have found out about if they didn't have this genetic testing. So it's certainly a mixed blessing sometimes, this genetic testing. It can have good sides, but as Dr. Musunuru said, it can also be very challenging.
So with this, we will conclude our session for today. This was really amazing. We learned a lot from our expert panel. We really appreciate you joining us virtually, and we hope that in the future we could have a session where we can actually have you here in our studio with us, once COVID-19 ends. Thank you so much. Any concluding remarks from the expert panel? Please go ahead.
Thank you for inviting us. It's been a real pleasure to be here.
Yes, thank you.
I'll second that.
Thank you, guys.
Thank you.
Thank you.